All right, welcome back. I am Captain Anna Ferris. I'm going to be talking to you guys about musculoskeletal traumas. So, trauma can be any range of things from, a sprain or a strain to, you got a whole limb off. Starting, kind of from least severe, and then we'll work our way over to kind of more severe situations that you may encounter in your career. Talking about sprains and strains and soft tissue injuries, biggest way to kind of manage those is with the RICE acronym. So you're going to rest it, ice it, you're going to provide some, compression and elevation, and that's all with the goal in mind of trying to reduce the amount of inflammation surrounding the area of injury. Biggest thing with these, no matter how minor, it's always a good practice to do a CMS check. Make sure that you've got, circulation, motion, and sensation in whatever area has been injured. And then any kind of intervention that you do, any bandage or dressing that you're placing, make sure that you document, your CMS checks. Sometimes they're called PMS checks, pulse, movement, sensation. But you want to document that before and after you place either a sling or, an ACE wrap or, a dressing. As far as stressors of flight, one consideration is kind of vibration. You don't want to put an injured extremity near something that's actively vibrating because you're just going to increase that pain. And then, let's see. As far as other types of interventions that you can do, there's non-pharmacological interventions. So positioning, putting the extremity in a position of comfort. As far as treating with, thermal kind of interventions, within the first 48 hours, you want to get some kind of ice on an injured area to decrease the amount of swelling. After that, the swelling is kind of already in place and it's sort of run the course of, that inflammatory process. And so it's oftentimes more comforting to have heat applied than it is to have cold on an existing injury. You want to elevate the area to try to reduce that inflammation as well. As far as aircraft considerations, again, not putting them near an actively vibrating part of the aircraft. And then also considering temperature. If you're in the KC-135 and you've got a patient that's floor loaded, they're going to be cold, possibly shivering, keeping them comfortable so that it's not actually exacerbating the injured area. So as far as assessing pain, according to American Nurses Association, pain is whatever the patient says it is. So we have no way of knowing how much a patient is hurting except by what they're telling us. So take them at their word, but also, kind of assessing what they're actively doing, and you can include that in their note. If they're, texting and, eating cheese puffs and, behaving fine, they may just have a different way of expressing the pain, but take that into consideration with your assessment. According to our regs, pain of 3, give them the D, give them some Dilaudid, give them whatever they have ordered. Something for the pain, but that's kind of your treatment threshold where you want to be thinking about some kind of pharmacological intervention. So one thing, something is, unassuming is like a sprain can actually have significant risk for even compartment syndrome, which is, a huge concern with any musculoskeletal injury. So what is a compartment? A compartment is any muscle that has a surrounding sheath, which is every muscle in the body. So you have fascia sheath, and it's just a tough connective tissue wrapper that goes around that muscle group. And if the swelling or bleeding within that compartment exceeds the stretch of the fascia, which is not much, you can develop compartment syndrome. So how is it diagnosed? Well, there are quantitative ways of diagnosing it. They can actually measure the amount of pressure within the compartment. But from our standpoint, without getting compartment pressures, you can look subjectively at, are they having pain like significantly disproportionate to the mechanism of injury? I mean, these patients a lot of times are just screaming coming off the bed because it's super, super painful. Paresthesia, so numbness, tingling, pallor. The couple times that I've seen compartment syndrome, these extremities are white, like they're not getting any blood flow. Paralysis, like when you ask them to wiggle their toes, they can't, or they might even think that they are, but they're not. Pulselessness is a big one, so it's a good practice again when you're doing your CMS/PMS checks that you're assessing, do they have a palpable pulse, and did they have a palpable pulse before? Poikilothermia is like, is it cold, like to touch? Are they not able to kind of thermoregulate that area? And that just kind of comes back to lack of blood flow. Is that bad? Yeah, that's bad. You need a surgeon to get in there and slice open that fascia to release that pressure so that you can restore blood flow to that muscle group. So what now? Fasciotomy. So as far as measuring compartment pressures, I will send along the slides for you guys to follow along with us, and if you feel so inclined, you can watch this fun video on measuring compartment pressure. So bone problems, common musculoskeletal process is breaking a bone. So after you break a bone, your bone goes through a whole process to get back to healing. So you have your inflammatory process that takes place, initially after that break occurs. As your osteocytes start like reforming bone tissue, it forms what's called a soft callus, and so it's kind of like this spongy area where there's cells that are trying to kind of come back together into like a bone matrix formation, but it's highly susceptible to re-injury. That's why, having a good cast on the area is also important. There's a hard callus phase, and that's kind of where the bone regrows in that area that's been broken, and it almost like overcorrects, and so you get a big hard callus where you can actually see it on the x-ray where they have kind of a lump around wherever they've had that break. And so that's where, the body's just throwing these osteoblasts out to the area so that it can get as much bone formation as possible. After it's managed to do that, you get to your healed phase where it's just remodeling. And so the remodeling is kind of the antithesis of that hard callus phase, where it's actually scaling back the amount of bone that's grown into that area to try to heal it and support it. So that's where you get your little osteoclasts, and they try to kind of smooth all that back out. So with fractures, you can have open fractures and you can have closed fractures. So this would be your closed fracture. It's still contained within the skin, but it's very obviously broken. That's where you have these, pretty gnarly deformities and stuff. In these cases, you want to do a good CMS check, and what you're doing is splinting the area for transport in a position of function. So, with this hand, that's not kind of normally how you would find it, and it's very possible that they're actually not able to get a radial pulse. So it's a big, thing for you to get a good baseline pulse. And so if they have a pulse, splint it as it lies. But if you're not feeling a pulse, you're gonna try to just as gingerly as possible get that to a position of function so that you can restore blood flow to that hand, because it's very possible that it has fractured in a way where that hand's not perfusing, and they could lose that hand from a very simple closed fracture. Do you think this is an open fracture? It's got my vote as an open fracture. An open fracture is any fracture that comes through the skin. So if the bone has come to the outside of the skin, you got an open fracture. These are a huge risk for infection. Obviously, big risk for bleeding. So you want to look and see, is the bleeding controlled, not controlled, is a tourniquet indicated? In this case, you know, I would be very concerned that this guy would be massively hemorrhaging, so you want to get a tourniquet on that. Big thing to consider with these is when was their last tetanus shot, and can you get some antibiotics on board, because again, really big risk for fracture. When you do get an infection down to the bone, there's only a handful of antibiotics that can actually get in there and take care of that. Osteomyelitis is an infection of the bone, and it's super hard to treat. A lot of times that's a big indicator for doing an amputation. So treating with antibiotics is going to be, you know, kind of paramount in these patients. As far as surgical repair, they can do an open reduction with internal fixation, where they actually like open it back up, they put in like a plate to kind of stabilize it, or you can have external fixation. And so that's, you know, we talk all the time about those X-fixes, and the big thing in the flight environment with that X-fix is making sure that it's not vibrating against something. So pelvic injuries are a huge emergency because you can lose so much blood into a pelvis. Pelvic injuries can accumulate up to 3 liters of blood. At that point, whatever they lose beyond that is kind of irrelevant, because they're probably not going to survive. The biggest thing is kind of closing the book. A lot of times these fractures are called open book fractures, because the break will take place at the pubis symphysis, and so it opens just like a book. And I do have a slide in here to kind of show you what that looks like. I talked about it a little bit in our trauma lecture, but a big way of assessing that is kind of rocking the pelvis. And only one person should ever rock a pelvis, and so it should be the first person that responds to the patient. A lot of times you'll find these patients, their legs will be kind of splayed out. They just don't quite look normal. If you kind of touch their pelvis and it feels like it's kind of wobbly, you're going to want to get some kind of a pelvic sling on there. They have T-pods, so they have like commercially available slings, but you can do it with a sheet. The big thing is positioning. If you're putting it kind of up on the wings of the pelvis like that, you're essentially splitting it open, and so you can clamp it down. You know, a big thing that people feel for is the hip bones, but if you're placing it up here, you're doing more harm than good. So you want to place it along the trochanter, so the widest part of their hips, kind of that hard knobby bone of their hip bone. You want to get it right under their butt and kind of yank it closed so that you're closing back up that book. So obviously another type of injury that you would be highly concerned with is a cardiothoracic trauma. You want to think about mechanism of injury. That's a pretty concerning mechanism. You know, if the whole front end of a car is taken off, you want to be concerned. If there's a steering wheel deformity, you want to be concerned. If you know, they had like a prolonged extrication, if there was no airbag deployment, if they were not wearing their seatbelt, you know, those are all really concerning for taking a heavy impact to the chest. As far as blunt trauma to the chest from, you know, any of those MVC type injuries, also like any kind of kick to the chest, especially like horses, cows, a hit with like a pipe or a bat to the chest wall, even just a lacrosse ball being, you know, winged into somebody's chest can cause a pretty significant cardiac trauma. So a big thing with these patients, if they're awake and talking to you and otherwise stable, it's still worthwhile to get an EKG, because that kind of disruption of the electrical activity from that assault can be enough to kind of throw them into a fatal dysrhythmia. And so you see that, I've seen that with a kid with a lacrosse ball to the chest. That ball hits right at the wrong point in their EKG rhythm, and it just thumps right on the T wave, and it can be enough to where it kind of stuns those myocardial cells and they can't kind of regenerate another impulse. So a lot of times, you know, something like that, you find them just unresponsive and pulseless, you know, check for a pulse, start CPR, do, you know, go through your algorithm, but it's also worthwhile, you know, get them on an AED as soon as possible, and you want to try to get them out of that rhythm. Another thing that can happen with significant mechanism to the chest is cardiac tamponade. So you would see JVD, distended neck veins. You can get narrow pulse pressures, hypotension, not responsive to fluid. If they have a significant mechanism to their chest, be thinking of cardiac tamponade. Not all fractures are created equal. Some are more concerning than others. Like I said, you know, pelvic trauma, chest trauma, very concerning. One you might not actually think of is calcaneal trauma. Like if they have fractured calcaneus, so their heel, that's a really big knobby bone, and it takes a significant impact to actually break that. So you've got to be highly suspect of, you know, significant mechanism of injury associated with that. Other concerning areas of fracture, sternum, again, very concerning for cardiac trauma, pulmonary trauma, great vessel trauma, scapula trauma, so your scapula, your little angel wings in the back there. Those are really thick, flat bones that tend not to break unless there has been a significant force generated against them. So those would all be reasons to maintain a high index of suspicion for some internal injuries or some more significant injuries that go along with it. So another concerning thing is chest wall instability. So a flail chest is something that you can get anytime you have 3 or more ribs broken in 2 or more places. It's a high risk for a hemo-pneumo situation where you get bleeding into the chest cavity, and it can rapidly deteriorate into a tension pneumo. And you no longer have the ventilatory assistance of your accessory muscles, and so that's why you get this kind of paradoxical chest wall movement. I'll go ahead and play this video for you guys, but it's embedded in the slides, so you'll have it to kind of go back and reference. So do you see that kind of seesaw motion where this is kind of staying steady, and it's that's always kind of a concerning sign. So speaking of pneumothoraces, you can have, that was a closed pneumo, you can also have an open pneumo, and that's kind of what you would refer to as your sucking chest wounds. Anytime you have bubbling or frothing at a chest wound site, you would be highly suspect of an open pneumo. A lot of times they'll have hemoptysis, so they'll be coughing up blood or spitting out blood. They'll have some difficulty breathing. They'll have that apprehension and, you know, that like I'm gonna die kind of feeling. You can have some subcutaneous emphysema, so that's, I mentioned it in the trauma slide series, but when you get air that escapes from the chest compartment and it actually gets outside of the pleura, and it can only kind of come out through the skin, and so you get the Rice Krispies that you'll feel when you're kind of touching along that. It's always concerning if you feel that. Essentially, any wound wider than the diameter of the trachea will develop into a sucking chest wound. So any penetrating trauma should be highly suspect for it. The treatment for these sucking chest wounds is you want to close the deformity. So you're going to do a chest seal. So TCCC will teach you to enclose it on 4 sides, and then to periodically burp your chest seal to let that accumulation of air in between the pleura back out. I came from, you know, kind of an older school background where we would tape on 3 sides, and it creates a chest valve where as they breathe in, the occlusive dressing will suck to their chest wall and cover that deformity, and then as they breathe out, they can expel whatever air is trapped inside their chest. The biggest thing to make sure that you do is to place the occlusive dressing at least a third wider than the wound is on all sides. It's very easy to suck a chest seal into a hole in the chest. My old paramedic partner when I was flying back in New York said when he was going through his medic ride-alongs, he was placed with a preceptor and they got a second chest wound. And so the guy thought it'd be super cool if he put one of the EKG dots over it, and he's like, there, see, like fixed. And on the next inhalation, the guy sucked the EKG dot into his chest wall. So that's kind of hard to hide, that you messed up that bad. So don't place anything that's not at least as wide as the actual deformity over to cover that, that hole. And again, if you're doing the four-sided technique that they teach you in TCCC, make sure that you're periodically burping that chest seal to evacuate the air that's accumulating kind of in there. And just always monitor for signs and symptoms of a tension pneumo. So be looking for the distended neck veins, the tracheal deviation, just that respiratory distress. So I'll go ahead and show this to you guys. This is a really good example of how you would decompress a tension pneumothorax with a dart. This is from the movie Three Kings.
Hey, you made the right choice today, Conrad. Stop with that shrine shit. Everything's gonna be okay. I know so. We'll get out of here. Hey, Mesa! Would you please fucking help us? God damn it! I feel better.
What's going on? Air pressure will hold up about every 15 minutes. Release the valve and you close it back up.
What can I keep doing?
I don't know. Maybe 4 or 5 hours from now.
So the biggest thing that I wanted to show you guys with that is once the chest was decompressed, he kind of indicates the need to follow back up. So air can kind of reaccumulate in that space, and so it's important if you've had to decompress a chest, chances are you're going to have to continue to decompress the chest. Hello, Elvis. So our landmarks for doing a needle decompression, so you're gonna have your second intercostal space, your mid-clavicular line is gonna be your anterior landmark, and if you're going laterally, you're gonna look for your fourth or fifth intercostal space, mid-axillary line. And you gotta have at least a 3¼ inch 14 gauge or longer IV catheter to actually make it to the pleural space. They make 5-inch. If you can get those, they're better for large chested individuals, and that's the only way that you can get deep enough in there to actually evacuate the air that you have to before it reaccumulates into a tension. So the other thing too to consider while you're doing that is make sure you're going over the rib, because there's a neurovascular bundle that kind of passes underneath each rib, and so if you're getting in there, those little thoracic vessels they tend to bleed a lot, and so you can easily turn a simple pneumo into a hemopneumo if you're not putting it in the right spot. So signs and symptoms of a tension pneumo, you get those distended neck veins, you can get tracheal deviation. That tends to happen a little bit lower down in the mediastinum, so it's not always visible, but I have seen it to where it is actually very visible too, so if that's something that you ever notice, that's obviously very concerning. The pressure of the air getting sucked into the chest cavity places additional pressure on the great vessels, and so you don't have your normal venous return coming back to the heart. So you'll see profound hypotension. These patients tend to just crash and burn if you're not getting that air out of there. Whoops, sorry. All right, so cardiac tamponade is kind of somewhat related. So you get your tension pneumo with air. Cardiac tamponade tends to be a condition of blood where it doesn't belong. If you have a cardiac contusion, if you sustain some kind of chest trauma, it's possible to develop a tamponade. So your heart has that really thick and tough sac that goes around it. If you get blood in between that sac and your heart, almost in the same kind of way that you can get compartment syndrome, you can get cardiac tamponade. So as it builds up, it can't fill back up, and so that space for the heart to expand within the pericardium is no longer available. And so sometimes with these patients, you'll see as little as like 30 cc's of blood in that pericardial sac is enough to kill somebody. So with that, an indicator of cardiac tamponade is called Beck's triad. I mean, in the flight environment, you're not going to necessarily be able to appreciate this, but you get muffled heart sounds. So you'll be listening and it sounds like the heart's very, very far away. You'll get distended neck veins. So as the pressure builds up in the heart and as blood starts kind of backing up and isn't able to actually come back to the heart, it'll back up into your jugular veins, and so you'll get those distended neck veins. You'll have decreased pulse pressures. So, you'll have a very narrow pulse pressure. So you may have a systolic of 140. Well, your diastolic may be 120. And, it's just your heart's not actually able to relax and, follow its normal flow. All this. You can get actually an EKG phenomenon called electrical alternans, and it's pretty much my favorite thing ever. You can't see it with Elvis in the way, but you'll get normal size QRS followed by a little teeny tiny baby QRS, and what that actually is the heart kind of swinging forward in the normal way, and then as it swings backwards in the accumulating fluid, it gets farther away from your EKG leads, and so you'll get that alternating big and little QRS complex. So the treatment for cardiac tamponade is going to be a pericardial centesis, where you go in underneath the xiphoid process and you kind of aim for the left shoulder with a big old needle. It's like a 14 centimeter needle. And you got a little stopcock on there, and then your big 60 cc syringe. If you're evacuating 60 cc's of blood out of a pericardium, man, you're gonna see a huge change in this patient's hemodynamics. Generally, like I said, something as little as 15, 20, 30 cc's of blood is enough to actually keep somebody, cause somebody to die from this condition. So even just a small amount of blood evacuated from pericardium makes a big difference. So you can also tell if you're in the right spot when you're doing this pericardial centesis. If the patient goes into VTAC, if you're actually tickling that ventricle with the tip of the needle, you went in too far. When you are pulling back, so you'll get back red blood, but it's now deoxygenated because it hasn't had a chance to kind of go back through that pulmonary vascular bed, so it tends to be darker than what you would pull out of the ventricle. But if you're pulling back bright red blood, chances are you went too far again. And then again, even removal of 5 to 10 cc's can increase cardiac output by 25 to 50%. So this is definitely a life-saving treatment. So penetrating chest trauma. So as we talked about in the trauma lecture, if you have some kind of a projectile penetrating, you want to stabilize it. You're not going to go pulling it out, because the chances of having, causing more harm than good in doing that are pretty high. So stabilize it, transport the patient in a position of comfort. You'll notice they didn't intubate this guy, they didn't lay him down flat. If he's able to maintain his airway sitting up like that, go ahead and, cut down whatever you need to get him inside the rig, or, wherever you're transporting him in, and, just enough to facilitate transport. But be prepared to manage the airway, be prepared to treat tension pneumothorax if it develops. Definitely be treating shock as you see it. And then if you see tamponade, also that's another thing that needs to be addressed. Another thing that can happen with chest trauma is diaphragmatic hernia. So your two kind of spaces, your interthoracic space and your intra-abdominal space, are separated by just a thin layer of diaphragm, and it controls, all of your breathing. That diaphragm is essential not just to the mechanics of breathing, but it's essential to maintaining kind of the discrete nature of those two compartments. So if something happens either by a penetrating force, it can happen if you have a significant enough blunt traumatic force, you can actually rupture your diaphragm. I've seen this happen, it's crazy. A lot of times, signs and symptoms will be, again, this is difficult to kind of determine in the flight environment, but if you're on scene and you see somebody and they're in significant respiratory distress, if you listen to them and you hear gastric sounds up in the chest cavity, it's highly possible that they could have actually had a diaphragmatic rupture. Again, you'll have significant respiratory distress, you'll have shock, because just like a tension pneumo, you've shifted your whole mediastinum over, and so your venous return is really poor. You get, again, distended neck veins, you'll get that tracheal deviation. You get hypoxia, anxiety, low cardiac output, delayed capillary refill. Immediate interventions for this would be to intubate. You want to take control of that airway. You want to maintain low tidal volumes, obviously, because you're not wanting to increase the interthoracic pressure more than it already is. You're going to want to decompress what you can decompress, so stomach, bladder, you're trying to reduce the amount of space. Another one that I don't have up here as far as like signs and symptoms, you may actually notice a scaphoid appearance to the abdomen. So their abdomen will look kind of hollowed out, and it's because they've sucked all that stuff into their chest instead. So it's a surgical emergency. They gotta actually like go in there, pull all that stuff back down, and then fix whatever the tear is in the diaphragm. So big thing to talk about is spinal injuries. Any significant MOI, you know, you always want to think, just like we talked about in the trauma lecture, stabilizing C-spine. You know, that should be one of your first actions on scene is, you know, does the mechanism dictate a need to maintain control of somebody's spine? Depending on the level that they sustain their injury at, it can have a significant impact in their outcome and severity of the injury itself. So rule of thumb is kind of C5 keeps them alive. That's the level at which the diaphragm is innervated. So if it's a high C-spine, chances are they're not going to be able to maintain the respiratory status, and they're going to have to be intubated. So when you're doing your rapid trauma assessment, when you get to the point of exposure and you're ready to turn that patient, you're looking for deformities or step-offs. I have seen those, you know, significant just through and through spinal injuries, and it's really noticeable when you have a step-off. You'll feel spine. Oh, not spine. Spine's back here. And so if they're malaligned like that, that's obviously really concerning. Loss of rectal tone, again, is an indicator of a spinal injury because obviously, you know, they're not able to communicate with that part of their body. It can lead to neurogenic shock, which is an emergency. And you should always, as a good rule of thumb, assume a spinal cord injury if there's ever an unwitnessed or intoxicated fall. So there's different types of spinal cord injuries. I know you can't see any of this, but when you guys get the slides, hopefully some of this kind of comes through. There's types of incomplete spinal cord injuries. So you can have like posterior cord syndromes, central cord, you can have anterior cord, and then you can have kind of these weird like hemiplegias too. There's a condition called Brown Sequard, where only half of the spine is, or spinal cord is actually affected. So you should presume if the patient has some kind of discoordination of their limbs, like if they're only able to do gross motor movements, you know, that's kind of concerning for if it's bilateral posterior cord syndrome. And so sometimes that can occur. You get a condition called CWORA, and it's a spinal cord injury without radiographic evidence. So that's another kind of thing where like you have a CT scan and it's clean, it's like, no, their spine's good. But if they're just totally discoordinated, if they have a loss of bowel or bladder function, you know, if they're suddenly stooling on themselves but they're completely alert and oriented, they could still have a spinal cord injury, but they're just not picking it up on a CT scan. In those cases, an MRI is a little bit better of a evaluation tool because it can see kind of variations that can get missed in a CT scan. So also remember the ABCs of first aid. A bone coming through the skin is very bad. So thank you for listening, and I will send those slides to you guys, and I hope you have a great UTA. Thanks.